So good morning. I think we are live now. It is a great pleasure to invite you to this W&H webinar on the management of peri-implantitis, a step-by-step approach. There will be some questions and answers session at the end of the presentation, so please
good morning.
Wait and write your questions on the chat function of the YouTube, and then I will try to answer them. This is without any doubt a very good outcome of implant therapy. In this case, where you have two implants in position 1, 2 and 2, 2, you can see that you have a perfect aesthetic outcome. And if you look on the conditions of the soft tissues around the implants, you will notice that it's a perfect healthy situation. Unfortunately, this is not the case always, as for example in this case where the implant in position 1, 1 has obvious a problem. You have a buccal recession, the implant is exposed. Now in this picture is covered with black, but if you get a probe and you try to check the pockets around the implant, you will see that we have a deep pocket on the mesial aspect. And just to set the frame, peri-implantitis is the inflammation in the peri-implant mucosa and a progressive bone loss after 1 year from prosthesis delivery, comparing to the bone levels after 1 year from prosthesis delivery, where we expect that the remodeling of the tissues due to implantation and other manipulation of the tissues is completed. Because in many cases we do not have this baseline X-ray, the recent consensus on the classification of periodontal peri-implant diseases has decided that we need to have a bone level at least 3 millimeters apical to the expected bone level after that initial remodeling phase, and a deep pocket of at least 6 millimeters to define a case of peri-implantitis. How much do we have of peri-implantitis? We have about 22%, as you can see from this systematic review, where a lot of studies were put together. This is the average, so it's quite a lot. It's about 1 every 5th patient that has implants showing peri-implantitis. Very briefly now on the pathogenesis of the disease. If we compare the anatomy of the marginal periodontal tissues with the marginal peri-implant tissues, we have some distinct differences. So in the marginal periodontal tissues, we have collagen fibers running in different directions here around the tooth, in different directions comparing to the long axis of the tooth, and of course we have the periodontal ligament. Comparing to the marginal peri-implant tissues, here you have a lot of collagen fibers running parallel to the implant axis. We have less fibroblasts generating these collagen fibers compared to what we have around teeth, and of course we do not have the periodontal ligament, and that results that the blood supply on the marginal peri-implant tissue is somehow compromised comparing to the marginal periodontal tissues, and that gives that has an impact in the pathogenesis. And if we look on these histological images from a tooth with periodontitis and an implant with peri-implantitis, we will notice that in the tooth side, where we have the inflammatory infiltrate on the lateral aspect of the pocket, here is the tooth. Beyond that, on a more apical extent, we have a zone of connective tissue that has minimal inflammation. So in a way, the body can keep the inflammation on the marginal tissues away from the reserving bone. In contrast, if one looks on the implant biopsy on the right part of the screen, you will see that the inflammatory infiltrate on the lateral aspect of the pocket is in direct contact with the bone, and in many cases it involves the bone marrow. So it appears that the situation here is more aggressive comparing to the situation around teeth. And just to illustrate that, I will show you these 3 X-rays, sequential X-rays from a patient in the clinic, in our clinic actually, taken with a difference of 3 to 6 months in between them. And you will see that if you arrange the X-rays so that the color of the implants on the same level, and I know that many of you will react on the marginal fit of the crown, it is correct. It is a very bad marginal fit, or there is no fit at all, but this is not what I want to say. I want to say that if you arrange the implants so that they are on the same level, and then you connect the bone levels on the first image to the left to the bone levels to the right image, you will see that obviously some extensive bone loss has occurred in a short period of time. And that is because the patient did not get adequate treatment. Yes, it can happen also in the best clinic in the world. So an important thing is that we should not wait to deliver adequate treatment in peri-implantitis cases, because the lesion is more aggressive comparing to a periodontitis lesion. So now when we have to treat a peri-implantitis lesion, there are many factors that they have to be considered during our treatment planning. This is the defect extent, the strategic position of the implant, the defect morphology, the implant surface, and also we have to take care of the soft tissue conditions. And of course we have the systemic factors, like if the patient is smoking or the patient has uncontrolled diabetes. Today we will discuss only the local factors that help in the decision making for the management of peri-implantitis. Now, in some cases, of course, the decision is taken. The implant cannot be treated. In this case, I just removed the bridge in order to be able to examine these 3 implants. And while I was putting the bridge on the desk of the chair, then the implant started moving up. So in some cases, we cannot do much. Just we have to remove the implant that is coming out by itself. Luckily, in most of the cases, the implants are in situ, and then we need to decide what to do. So the first thing that we have to look on the extent of the defect and the strategic position of the implant. Look in this case. In this patient where we have a breach based on 6 implants in the upper jaw, the only implant that has a problem is the distal one. The rest of the implants, they had shallow pockets of 1 to 2 millimeters, slight bleeding, so only mucositis, and the only implant that had deep pockets was the one on the distal aspect. And you will appreciate that on this X-ray, where you can see that the bone defect goes almost to the apical extent of the implant. So in this case, the defect is too extended, that the outcome of treatment will be, let's say, compromised anyways. It will be difficult to achieve complete resolution of the defect and the lesion, but also the energy that we will need to put to keep an implant that is in the reality not necessary for the survival of the prosthesis. It doesn't make sense. So in this case, the reasonable solution is to take off the implant, maybe cut off the one tooth, the one of the hanging elements here. Then the patient will keep the same prosthesis, maybe have one tooth shorter. It's not necessary that this has to be removed. It depends a little bit on the distance between the last implant and the last cantilever, and then in a very fast and efficient way the problem is solved. So the strategic position of the implant and the defect extent are the main first thoughts that we have to make when we look at a peri-implantitis lesion. Then we have to put, then we have to follow a sequence of steps in order to have a logical and good outcome of our treatment. There's no universally accepted method of treating peri-implantitis, but in this consensus conference of the ITI, a logical set of steps, of sequences that have to be made when treating peri-implantitis has very nicely described by Hayes Mayfield and collaborators. So the first thing is that we have to reduce the risk factors for disease. And of course, the main risk factor for disease is our biofilm. That means that the patients have to be able to perform high levels of oral hygiene if we want to have success in our treatment. One thing is that the patient have to be motivated and be able to and be willing to make the effort to perform good oral hygiene, but also we have to allow them, or at least the prosthesis has to allow them to be able to perform a high level of oral hygiene. So look on this case where we have this 3-unit breach in the lower jaw. Both implants, the first, the premolar and the molar, had deep pockets. And when I removed the breach in order to be able to examine better the case, I saw this thing here. As you can see on the molar, we have this buccal extension, this saddle, covering completely the ridge. And of course, you can imagine that in this aspect here, it's completely impossible to brush, even if the patient was the best brusher in the world. This aspect cannot be cleaned efficiently. So in this case, one has to modify the prosthesis. One has to take off the saddle, which I cannot explain why it was put there, because there is no reason of course, any aesthetic concerns in the molar aspect in the lower jaw. This has to be removed, grounded up, in order to give the possibility to the patient, to the motivated patient, to brush efficiently the area. So that is an important aspect that many times we tend to forget to perform, but it's a very crucial aspect for the success of treatment. Then we have to do the non-surgical debridement. This is a step that we perform always, even in the cases where we already know that they would need to go to the next step, to the surgical phase. This we do in order to reduce the bacterial load on the implant surface, and this way reduce the inflammation of the tissues, which will allow us to have a better manipulation of the tissues, but also will give a better potential for the body to tackle the problem. So now, non-surgical debridement, we use different instruments, or there are different available instruments out there. We have curettes, plastic or metallic curettes. The plastic curettes were the first that they came up to the market. They are very difficult to use. They tend to break. And then you have small tips of the curette into the pocket, and it's impossible to find. Quite popular are these tips, that they are specific tips, ceramic or with a PEEK coating placed on the ultrasound unit. Then we have the, during the more recent years, last 5, maybe 7 years, we have these airflow devices, and then we have also lasers. As I said, these are quite popular. However, they are not so handy to use. As you will see in this case here, they are rigid and they are difficult to get into the, they're quite thick, they're difficult to get into the pocket, and they are also impossible in many cases to bypass the curvature of the prosthesis in order to go easily into the pocket and then have a parallel have a tip parallel to the implant axis. These are useful to remove the hard deposits on the implant surfaces. So these are good to use for the calculus that you can sometimes find in implants, but they are not so easy to use and probably not so efficient to remove the biofilm. So the new trend is to use the air policing devices. They are different models. They are desktop models, so you can have a separate unit you can put on the side of your chair. They are hand pieces that you can connect on your unit. So they're different devices. They have different configurations. When we want to go subgingivally, submucosally in a peri-implantitis case, we have these elastic tips, this specific airflow devices from W&H, and as you can see, it has this elastic tip that bends nicely, can get easily into the pocket, and throws with pressure powder and water, and that goes and removes big part of the biofilm on the implant surface. It's much better, although you can bypass the prosthesis with these elastic tips. It's much better, of course, to remove the prosthesis. And what you do is you go up and down. I will just go back and show it again. You go up and down all around the implant surface. You do not stay still, and remove in this way the biofilm from all around the implant. They are easy to use for us, for dentists, very handy. They're also very patient friendly. In most of the cases, treatment is without anesthesia. There have been some concerns that these devices may cause emphysema. Of course, they can cause emphysema if they are not used properly, or if we do not really think what we do. So in cases where you have deep defects on the lingual aspect of the implants, of course you have to take care that you do not push the air in the sublingual area. So usually when I have such a case, I'm careful. I really try to see where the extent of the defect goes, and if it goes beyond the floor of the mouth, of course I'm extremely careful and I avoid to use this device. In the other cases, I try to press with my finger tied to the tissues to have a mechanical barrier for the air. Now the thing is that in the majority of the cases, non-surgical therapy of peri-implantitis, even with the air policies, is not effective in disease resolution. We have a clear tendency for disease recurrence. So this part of therapy may give successful results in incipient peri-implantitis. And it's a little bit difficult to define what is incipient peri-implantitis. There are different cutoff of bone levels, bone level values to define incipient peri-implantitis. But let's say in an everyday rule, defects of 1 to maybe 2 millimeters can be, in some cases, be treated only with non-surgical therapy. Otherwise, in cases where we have more than 2-3 millimeters of bone loss, then surgical therapy is a necessary step. In this way, since we know that we have to do the next step, we usually do an early reassessment of the non-surgical phase in order to get the advantage of the early wound healing due to the removal of the biofilm, where we have a low level of inflammation. And then after these 2-4 weeks, we will do a surgical intervention. So we have to open up the flaps, and the aim is to first decontaminate the implant surface, and then we have to decide whether we do a resective or a regenerative approach. Now, when we open up, we will see that we have different types of bone defects. So defect morphology is the next important thing in our decision making. We have defects that they are primarily horizontal. As in this example, we have defects that they are primarily intrabony, maybe in combination with some horizontal bone loss. We have defects that they are dehiscences, they are quite common. And of course, we have combinations of dehiscences with intrabony defects and or with some marginal horizontal resorption. Defect morphology is important because it defines the regenerative potential of the site. So if you look now on this upper left image where you have bone all around the implant, almost at the top of the implant, of course it makes sense that this defect has a better potential for regeneration comparing to a defect that looks like that. Look on your lower right of your screen where you have a primarily horizontal defect. And indeed, it's true that these type of defects in a study where a regenerative approach was followed, the authors could see that circumferential defects, or class 1E defects as they are classified according to the Schwartz and colleagues paper, had a significantly better response in terms of clinical attachment level gain, so 2 times more clinical attachment level gain and 2 times more probe pocketed reduction in these type circumferential defects comparing to defects where one of the bone ones was missing. So like these class 1B and 1C defects where the buccal aspect of the defect is missing. And actually when the looked specifically on which aspect of the defect did not respond to therapy, to the regenerative therapy, was indeed the buccal aspect, so where the bone was missing. So defect morphology is important. Then the other important parameter that we have to evaluate when we have opened up is the implant surface. If you look in these 2 images, highlighted images, we have implants of similar macrogeometry, so threaded external hex implants, but with different microstructure. Here you have an old-fashioned low-tech machined implant, and here you have a modern high-tech roughened implant. Implant surface is important for 2 reasons. Let's look at a preclinical study where we can illustrate one of the reasons. In this study, implants of similar macrogeometry but different surface with different surface characteristics, a machine and a rough implant were placed in the dentulated mandible of dogs, and after osseointegration, ligature-induced peri-implantitis was performed. After some months, where you can see that we have a bone loss of about 30%, 30 to 40% of the implant height, the implants were revisited, so they made open flap debridement, they removed the granulation tissue, and they took gauze with sterile saline and rubbed the implant surface to decontaminate the implant surface, and then cleaned, and then closed up, so no regenerative approach. And 6 months after healing, where biopsies were performed, they could see this outcome. So on the left aspect of your screen, the outcome around an implant that was with a machine surface, and on the right aspect, the outcome of treatment of an implant with a rough surface. And the red box shows the pre-existing defect. And as you can see, in both cases, we have bone formation up to the entire, almost up to the entire extent of the defect. But if you are very observant, you will see that bone to implant contact, so new bone formation on the implant surface, on the left image has occurred only on the bottom aspect of the box, while on the right image, bone to implant contact has occurred in the entire extent of the newly formed bone. So indeed, reuse integration on a previously contaminated implant surface was 3 to 4 times more in rough implants comparing to machined implants. So implant surface is important for the potential of reuse integration. Now the other important aspect is exemplified with this study. Again, the same model where implants of different macro and surface characteristics were placed in dogs. Experimental peri-implantitis was induced, and then they were treated with open flap debridement, so with a somehow, let's say, low-tech approach, and the implant surfaces were decontaminated with a gauze with sterile saline. You will notice that after healing, we have distinct outcomes. Here, there have been 4 different types of implants used. On the very left, an old-fashioned machined implant, And then the next, and the third and the fourth image are from modern type of implants with a moderately rough surface. These are implants for major producers, so they are clinically available implants. But what is important is not which is the brand behind the images. The important is the conceptual thing of the case. So looking on the left, you will see that we have a very nice healing where we have epithelium in close contact to the implant surface, and then we have inflammation-free connective tissue adhering on the implant surface, and a little bit of bone regeneration on the bottom of the defect, as we have seen before. On the other images, you will see that there is a variation in the amount of residual inflammation. Here in the second image, we have a little bit, here you have more, and here you have much more. And to make it easy, I have put this green mask showing the extent of the inflammation, the area of the residual inflammation after treatment, and you can see it's distinctly different in terms of sizes. But also you will see that it's also distinctly different in terms of the apical extent of the inflammation. The larger distance of the little inflammatory infiltrate that you have on the machined implants, and then you have the inflammatory infiltrate in the three different modern structured implants at different distances. And actually in the right image you will see that you have a very large inflammatory infiltrate in tight contact with the bone surface. So basically here you have an active peri-implantitis lesion after treatment. So implant surface and implant surface characteristics, not the roughness per se, but the characteristics play important role also for the amount of residual inflammation due to the potential to decontaminate efficiently the surface with, and that is an important aspect, with a low-tech approach. Because in these studies, the decontamination method was taking a gauze with sterile saline and rubbing the implant surface. And of course, one would say that the best outcome you will get if you remove completely the biofilm from the implant surface. Then when we open up, we have different means to try to decontaminate the implant surface. We have mechanical and chemical means, just to make a gross distinction, but usually we talk about combinations. Now the thing is that no method can achieve complete biofilm removal. These two references are on systematic reviews on laboratory studies looking on mechanical means and chemical means separately to decontaminate the implant surface. So no method can achieve complete biofilm removal in the laboratory, and then you can imagine that this is impossible in the clinic. That's why we have to use both mechanical and chemical means. Now the catch again is that we do not know which method is the best. We do not have data supporting one method over the other. And that's why, in a way, everybody is using what one has available or what one thinks works better. We are using hydrogen peroxide 3% on a gauze where we are cleaning the implant surface by rubbing it in cases where we have a good and easy access to the surface. In cases where we do not have easy access, then we supplement with other devices, and you will see it later on. So now in this case here, we have a primarily horizontal defect, and we have an old implant surface, a low-tech implant surface. So we have a defect that has limited potential for regeneration, but allow us to have good access on the implant surface for decontamination, and then we have an implant surface that is relatively easy to decontaminate, but also has limited potential for regeneration. So in this case, the approach should be relatively simple. What we do is a resective approach, So in this case, the easiest would be to remove a little bit these peaks here of bone, to flatten a little bit the defect, decontaminate in an easy way, in a low-tech approach, since we have a low-tech surface, let's call it like that to make it easy, and then we just close. That would be an easy way to go. And I have a case showing that. And again, I know that many will react about the prosthesis. Well, the patient did not care about the prosthesis. He was functioning very well. He was an old patient, but he was functioning very well. His problem was the infection and the inflammation around the implants in his lower jaw. So we did like that. We opened up, and you see how it looks like. And what I did is I removed a little bit the peaks here, made a little bit flatter the defects, decontaminated with gauze in 3% water peroxide, putting it around the implant, and then rubbing the implant like we do with a towel in the douche, so that it goes everywhere. We use the hydrogen peroxide 3% because it bubbles, so you have the feeling that it goes better everywhere. It is actually that. We do not have an evidence that this is a better method of decontamination than sterile saline, but the hydrogen peroxide does not alter the chemistry of the implant surface, let's say, comparing to chlorhexidine. So this is what we usually do, and then of course we clean with sterile saline. Now is the result of this specific case. After approximately 1 year of treatment, shallow pockets all around the implants, and you can see we have some exposure, of course. So we have some recession and exposure of the implant surface, but this is not a big problem because the patient can clean here in the front. This is a low-tech surface, so the potential to mechanically clean the surface is much better comparing to if you had a modern roughened structure. And this is comparing to a baseline. And here are the X-rays where you can see stable bone levels 1.5 years after treatment. Now looking on this other image, on the other aspect of your screen, we have a similar defect configuration as the previous case, so primarily horizontal. We have the same structure of the implant, so it's a screw type of implant, but we have a different implant structure. We have a modern implant structure, a micro roughened implant surface. So here we have a low potential of regeneration on the site. We have good access on the implant to decontaminate, but we have a surface that is difficult to decontaminate efficiently because it's roughened. So that means that our approach cannot be so simple as before. It has to be a little bit more advanced. Again, it has to be resective because we do not have good potential for regeneration, but this time the resective part will be also on the implant surface to decontaminate efficiently the implant. So this is done by removing the threads and the surface. So we do what we call implantoplasty, and there is some evidence supporting this approach. This RCT study from Italy actually is the only RCT study looking on this treatment approach, where implants or patients with implants with a roughened surface were divided in two groups. One group received the classic open flap debridement approach, a little bit resective surgery. The other group received also implantoplasty, where the threads and the surface was removed with diamond burrs and was polished with silicone polishers. And what the authors could see was that after 3 years of treatment, the majority of the implants treated with implantoplasty, so 90% of the implants, showed a low tendency for bleeding, while the majority of the implants, 80%, treated with an open flap debridement, so a large tendency for bleeding already after 2 years. And you will say, but why this is 2 years and this is 3 years? It is because after 2 years they realized that implants treated with the classic open flap, simple low-tech approach, open flap debridement, continued to lose bone. They lost 1.5 millimeters, comparing to the others that they showed stable bone levels. And in this way, they had to cut, break, abandon the study, and then treat also that group with the implantoplasty. And indeed, there are some case series, primarily case series, reporting on implantoplasty. As you can see here, this modern study published last year. Do not have too many implants, but basically shows the same outcome. But after 2 to 6 years, these 32 implants treated with implantoplasty, the vast majority saw disease resolution. That means shallow pockets and no bleeding on probing. And of course, this is not a panacea. So this treatment is not a panacea, so some implants in that specific study were lost because of continuous breakdown. But then in this case, you have to consider that maybe those implants were so much compromised from the beginning that they shouldn't have been treated in the first place. That I do not know, it's a speculation. But in general, again, a very good outcome for the majority of the implants is reported with this approach. Now let's look on another study reporting on the long-term outcome of treatment 2 to 11 years after surgical therapy for implantitis. Here, 50 patients with implants were treated with standard, this low-tech approach that is used to be performed on that clinic, where implants were opened up, flaps were opened up, implants were approached, cleaned with a gauze, soaked in sterile saline, and then maybe a little bit also recontouring were indicated, no regenerative therapy. These are the results of one case in the publication 10 years after. You can see a very nice outcome with stable bone levels. But if we look on the table here, so where we have the summary of the results, you will see that implants with a modern type of surface, roughened surface, they showed on an average a pocket of 5 millimeters, which is okay, but maybe not the best outcome. But the problem here is that not only that the majority of those implants were, that the average pocket depth of those implants was 5 millimeters, but the majority of the implants, or 80% of the implants, were bleeding. In contrast, when looking on the low-tech machined implant surface implants, we had an average of bone pocket depth, of 4 millimeters, and the majority of the implants showed a low tendency for bleeding. So from this study, one can see that if you have modern type of implants, a low-tech approach in the majority of the implants will not give a sufficiently good outcome, while if you have a turned implant surface and you do this low-tech approach where you just open up, use a gauze in sterile saline and rub the implant surface, in the majority of the implants you will get an acceptable or a good treatment outcome. So a low-tech approach may function for the most of the cases in low-tech implants. However, it will not function in most of the cases in high-tech implants, just to make it somehow simplistic. So here's another case just to exemplify this way of thinking. This is a patient with 2 full bridges on implants in both the upper and the lower jaw. Both jaws had severe problems. I will show you only the lower jaw, just to make it, let's say, consistent with the previous case, where you can see the extent of the bone loss. So here is the first surgery where we open up, and here we see the extent of the bone loss and also the configuration of bone loss. Now in the middle, you can see that this implant has a really extensive bone loss. So here comes again the extent and strategic position of the implant. This is the middle implant. To put too much effort to treat this implant doesn't make sense. So this implant here was removed, and then the 4 remaining implants that were sitting quite well into the bone were treated with a resective approach with implantoplasty, where threads and surfaces were polished, and then of course we decontaminate with sterile with hydrogen peroxide, and a gauze, of course, with a sterile saline rinsing away the remnants, and then just clean up, closing up, so no attempt to regenerate. And here I have the outcome of healing 12 months after treatment. So again, you can see shallow pockets in all the implants and low tendency for bleeding. Of course, we have some recession, but that was that is a, let's say, wishful result in such a case. And here you can see that this patient is not the best brusher in the world. Actually, this patient is also among the heaviest smokers in the world. He smokes 4 packages of 3-4 packages of cigarettes, and every time he comes, he says that next time he will quit smoking, next time he will brush much better, but it doesn't happen. And again, you can see that with this approach, you can get some good outcomes also in patients that they are not the best candidates. Of course, you will ask me, yeah, but how is the long-term success of treatment in these cases? I have to admit that this patient does not go really well. So after 2 years, he started to have recurrence of disease. But as I said, he's not brushing well and he's smoking like a hell. So, you know, we cannot do miracles. And of course, we have cases where we have combination of defects. So in this case here, you see we have an aspect of the defect where we have a horizontal bone loss, so we have a buccal dehiscence, and here you have limited potential for regeneration. And then the remaining defect has an intrabony component. So here you have difficulty to access to decontaminate the implant surface, so you need to do something more, but you have an intrabony component that has a higher potential for regeneration. And also you have an implant surface that is modified, so it's a modern type of implant, a high-tech implant, that also gives good potential for regeneration. So one would think that it makes sense to remove the threads and the surface on the buccal aspect to efficiently decontaminate that part of the implant where we do not have potential for regeneration, but do our best of efforts to decontaminate the implant on the aspect of the defect where we have good potential for regeneration and reduced integration. So we have to do a combination approach. And then we can consider regenerating defect with the use of a bone graft in a membrane. At least the best outcomes are reported when you use a graft in a membrane. And it seems that this way of approach works. This is a study reporting on a cases treated in this way, where the buccal aspect of the defect was treated with implantoplasty, so removing the threads of the implant, and then the intrabony component was grafted with, in this case, with deproteinized bovine bone and a collagen membrane, and you can see the outcome of healing 4 years after. Very nice outcome of healing. Indeed, the majority of implants treated in this way, they had a low tendency for bleeding, they had a shallow pocket, and they had a relatively okay clinical attachment level gain. Now, what to use for grafting? One can use autogenous bone, one can use xenograft or alloplast, and one can use combination. We do not have data enough to say that this type of graft is better than the other. I prefer to use primarily autogenous bone. What is important is that you do not overfill the defects. We want to use the graft just to support the blood clot and give some stability on the system during the early phases of healing. You do not need to really fill up the defect space, because in this way you eliminate space for new tissue formation. So I have a case here with a combined surgical approach. You can see 2 implants in the upper right. The distal implant has the biggest defect. You can appreciate it here in the X-ray, where you have bone loss of about 50% of the implant. After the non-surgical phase, 3 approximately 3 weeks after was, in this case, the patient came in and we did the surgery. So you can see we start with a slightly paramarginal approach, or on the top of the mucosa on the buccal aspect to minimize the recession, and then on a paramarginal approach on the palatal aspect, you go 1 millimeter from the margin of the mucosa to facilitate flap elevation, but also to facilitate the removal of the granulation tissue that is in many cases easy to remove as in a whole piece, like a manchette, as you will notice in this case. When we debride the defect, we use titanium curettes, especially in cases where you have implants with a transmucosal component, and that would do in order not to scratch the implant surface and make it more rough. Here I use liquid rubber dam to isolate the bone and especially the soft tissues in order to avoid or minimize the decontamination of the tissues with the metal particles that will be generated from implantoplasty that will be performed on the buccal aspect of the implants, where you have the dehiscence and then the limited potential for regeneration. So the buccal aspect was, the threads were removed from the buccal aspect, and then the implant was polished. The remnants of the rubber dam are removed, and then we use an air polishing device to come and decontaminate the intrabony component where access is difficult. Then clean the remnants of the air polishing device with sterile saline, thin a little bit the palatal tissue to allow a better adaptation on the palatal aspect. Again, decontamination, the next step with hydrogen peroxide 3%, cleaning with sterile saline again, and then harvesting a little bit of autogenous bone from the neighboring area with the raspatorium. In the majority of the cases goes really well. You need to have a sharp raspatorium, and as I said, you do not need to take too much. You just need to put a little bit in the intrabony component to support the blood clot, to have a better stability of the system. And then after you are doing that, then a collagen membrane on the top, again with the purpose to stabilize the mechanically the clot and the system. The membrane here is placed as a poncho, so I try to put it in one piece and avoid to have vertical cuts on the membrane. Membrane is placed around both implants, and pressed under the flap, getting it wet so it gets stabilized. You do not need to suture the membrane, of course, and then you reposition the flaps and suture with 5-0 Prolene suture. And here are the outcomes 3 months post-op, shallow pockets and no bleeding problem. Of course, you have some recession again, but this is again a wistful outcome. And here are the Xrays where you can see progressive bone loss, progressive bone filling on the previous aspect of the defect. We use a specific kit of burrs to do the implantoplasty. There are different producers out there. I do not have any specific agreements with any company, so it's just to illustrate to you that you have different burrs with different configurations and different cutting capacities in this type of sets. An important thing is that you have to remove the breach, the prosthesis wherever possible to improve the access. Look on the left aspect of the of your screen where the breach was not possible to be removed, and you will notice that the implant surface is not as smooth as in the right aspect of your screen where we could remove the breach. The difference is evident. Now, since we remove a part of the metal, of course, a relevant concern is that the implant becomes weaker, it may fracture. Of course, another relevant concern is that when we burr metal on metal, it may generate heat, and the heat may jeopardize osseointegration. And then, of course, we have this discussion with the particles that they sit into the tissues and they may give maybe a cause of inflammation. Well, we did a systematic review exactly to answer the question of whether there are complications, biological or mechanical, after implantoplasty, and we were quite inclusive, so we collected whatever studies there were out there, laboratory studies, preclinical studies, or clinical studies reporting on implantoplasty. And in a nutshell, here are the results of that systematic review. Implantoplasty does not result in temperature increase provided that you use proper cooling, so your normal surgical handpiece with sterile saline irrigation. Implantoplasty, yes, indeed, it leads to reduced implant strength. It makes sense since you remove part of the metal of the implant, they become weaker, they can break easier. But this appears to be relevant in standard or regular diameter implants, but not in wide diameter implants. Also depends a little bit on which implant system you use. Titanium particle deposition in the surrounding tissues is of course possible. You cannot completely isolate the tissue, so you will get some decontamination with titanium particles. However, no clinical study has reported any remarkable complication due to implantoplasty, non-mechanical or biological. And of course, you can argue that there were not too many implants included in this study. It was a range of 217 to 291 implants. And you can also ask, why is this difference? Well, this difference was because one of the studies did not clearly report the number of the implants. So that's why we have informed the range of the implants. However, no implant fracture has been reported. And I would say that if implant fracture was a common problem in cases of implantoplasty, that would have been published for sure. The only complication that we could identify in that study, in the systematic review, was a single case of mucosal discoloration. So there was a mucosal tattoo. So this type of approach has been actually confirmed, let's say, in a recent consensus conference dealing with peri-implant diseases. So in that consensus conference was reported that surgical augmentative peri-implantitis therapy results in improved clinical and radiographic treatment outcomes in the majority of studies. There is no evidence to support the superiority of a specific material, product, or a membrane in terms of long-term clinical treatment benefits. There is no method of implant decontamination that can be suggested as superior. The treatment outcomes seem to be influenced by factors such as the peri-implant bone defect morphology and the implant surface characteristics, as we discussed. Now, going towards to the end of the presentation, what about antibiotics? It is common to use antibiotics when we do peri-implantitis therapy. However, a study from Sweden has addressed that in a systematic way and has shown that antibiotics seem to be beneficial for rough implants, but not for machine implants when treated with a resective approach. So when you do a resective approach and have an old-fashioned low-tech implants, antibiotics seems not to be necessary. In this study, they also reported that over the long term, the added benefit of antibiotics seems not to be sustained, so meaning for the rough implants seems not to be sustained over 3 years. But again, here remember that this treatment or this group of researchers use a low-tech approach when doing surgery to decontaminate the implant surface. So antibiotics have a positive effect for modern type high-tech implants over the short term, but not over the long term. Again, in cases where decontamination was done low-tech, so with a gauze and sterile saline. So as a resume of the step-by-step approach, the first thing that you would do after you open up is you have to look on your implant surface. Is it a machine, a low-tech implant, or as a roughened high-tech implant? Then you have to look on your defect configuration. So if you have a machine implant and a horizontal defect, you have to do a simple approach, debridement and a resective approach. If you have a horizontal defect on a rough implant, then you have to do implantoplasty. Again, a resective approach, but a little bit more advanced. If you have intrabony defects, you have to consider doing a regenerative approach if you have a machine surface, or knowing that you will not get much osseointegration, but you will get a good regenerative outcome, and that maybe it makes sense in an anesthetic case. If you have a roughened surface, you should do a regenerative approach. And of course, if you do a regenerative approach, you give antibiotics in order to get the full potential of the site where you have a good regenerative potential and also a good potential for reosseointegration due to the roughened surface. And if you have combination of defects, of course, you have to combine implantoplasty with an augmentative approach as we described before. And this is the flow. Just to take, if you want a picture of that slide, where it shows the steps, the different steps, so the step-by-step approach and the combination of treatments. Just to show you how it works, at least in our hands in the clinic in Malmö, where I used to work for some years, we are bringing the patients in and make a re-evaluation of the treatment that we have performed the last 4 or 5 years, and up to now we have collected only 60 patients. It takes some time, as you know, with 110 implants. And we can see that within the 1 to 1.5 years after treatment, 70%, 67, so approximately 70% of the implants showed shallow pockets up to 4 millimeters and no bleeding problems or complete disease resolution. Another 10% had pockets of up to 5 millimeters but no bleeding problem, or maybe 4 millimeters that bled. Again, quite good outcome, so about 80% of the implants showed quite good outcome of treatment. 50% showed pockets more than 5 millimeters with bleeding or problem, so not the outcome that we would like to have, but consider that in this group we have implants that started with 12, 11 millimeters of pocket depths, so still a significant improvement in many of these cases, but not an optimal outcome. And of course we had 8% of cases where treatment was not successful. As I said, this treatment is not a panacea, but it works quite well in the vast majority of cases. Last thing is that you have to consider also the soft tissues. Look, in this case where I have completely movable mucosa around the implant. In this case it's very difficult for the patient to cling, so it really it seems that the evidence is emerging that absence of an adequate zone of keratinized mucosa, and we usually say 2 millimeters around implants, is important, especially in erratic patients, or patients that do not come for maintenance as they should come, because they it appears to be associated with peri-implant diseases, and that may make sense since we know that absence of keratinized mucosa or adequate zone is associated with a higher risk for mucositis, and mucositis is a stage of peri-implantitis. So in summary, non-surgical therapy of peri-implantitis is not effective in disease resolution. You have to consider the defect morphology and implant surface for the surgical approach. You have to do a resective approach, primarily horizontal and wide defects. You have to do a regenerative approach in intrabone and narrow defects. You have to consider to do implantoplasty, or you have to do implantoplasty in rough implants and at sites with limited potential for regeneration. And also you have to consider the presence of keratinized mucosa, because it appears to be relevant. Thank you very much for your attention. My name is Andreas Stavropoulos, and I'm professor at the University of Geneva, Division of Regenerative Dental Medicine and Periodontology. And I will see if there are any questions, and I will try to find them. I can see there have been some questions here. Okay, most of them they are related to the system. I can see in the presentation, but not on the content. If you have any questions on the content, please write them in the YouTube window, and I will try to answer. Well, it appears that we do not have too many questions, so I hope that everything was clear. If there are questions, you can drop me an email. The email, I guess, is available at W&H, and I will try to respond on your queries. I hope that you got an overview of how one should deal with peri-implantitis in a logical step-by-step approach, and as you could see, it makes sense, and it appears that we can get quite good results in the majority of the cases if you follow this way of thinking and treating peri-implantitis. Thank you very much for your attention.